other stuff going on. Anyone want to sort of tell me what they think? Are we happy with this guy? You're going to leave him?
No.
Why?
Put that Hudson mask on.
Sorry?
15 litres.
Mm.
A lot of oxygen for CO2 then.
Yeah. So, I guess that's one of the first myths that we can sort of dispel here. I agree wholeheartedly. If you have someone on the ward that's a CO2 retainer and you put them on oxygen, you run the risk of decreasing their respiratory drive and causing problems. However, when you see this, do you think the issue is that he's a CO2 retainer, or do you think the issue that you have to deal with is the hypoxia? Yeah. So don't let the whole CO2 retainer thing that you get taught that scares you think don't give these people oxygen. Okay. When you see someone, the hypoxia is what's going to hurt their organs first. So deal with that. If they don't breathe and you have to tube them, so be it. Someone will be there to help you do that, and you can deal with it. But if they die because they're hypoinfused, it's a bit awkward because you were sitting there with nasal prongs because you didn't want to over-oxygenate them. Okay? So what else?
He's on like maximal oxygen, his stats are still not great, and he's working really hard at deadlines, so I'm really concerned about him.
So if you had to like call up your registrar because the MetCall page thing isn't working or something, and you know you've got the registrar phone number, how would you describe this guy over the phone? Like, what would you say? Any specific keywords you want to use?
Increased work of breathing.
Yep.
Possibly leading to like type 2 respiratory failure.
Good, so you're touching on respiratory failure. So at least we can all sort of assume, having a look at that, he's in some form of acute respiratory failure. Can we all agree on that? Sort of. It's not quite acute respiratory distress syndrome because it's a separate thing, which we can talk about after if you want. But he's failing. He's on huge amounts of oxygen. He's working as hard as he can. His rest rate's through the roof, and it's not doing anything. So then we always get told about, I used to hate these things, the type 1 and type 2 and what the fuck that meant. And at the end of the day, I guess all it really allows you to do is to look at an ABG like that and sort of work out what's going on and if it's normal or if it's abnormal. There is obviously what you're going to more commonly see. In someone with COPD, you're likely that they're going to be hypercapnic anyway. So they'll be hypoxic and hypercapnic, which is again why I don't necessarily like the definition, because you don't really know if the failure that they're going through is secondary to their normal base hypercapnia, and that's why they're hypercapnic, so it's actually a type 1, but, you know, or is it actually some sort of problem that's causing a poor ventilation and therefore an elevated CO2. But having said that, it always gets asked. So type 1 is low oxygen with a normal or low CO2, and type 2 is a high CO2. And like we sort of said before, the threat that you have to worry about is hypoxia, not the CO2. So you get it, you look at it, and it's great, but the oxygen is the thing you care about, okay? So put oxygen on these people straight away. So this is sort of ALS-y stuff. Airway, breathing, circulation. This is all the stuff that you should do with anyone you see, and you just have to jump through some stages quicker than others. So anyone that has acute respiratory failure, you want to assess their airway pretty quickly, and basically the idea of assessing their airway is not necessarily if it's blocked, because you'll work out if it's blocked really quickly, but more, especially with the guys that are in hospital for a while, they're not going to have accidentally swallowed something in the middle of the night. It's more to assess, are they going to be able to protect their own airway for a long amount of time? Because if they're not, get help there early. If they're not going to be able to do it, just get someone there, okay? Don't muck around and waste time to get to deal with disability and work out a GCS or something. If they look bad, get help. The breathing, like we said, O2, whack it on. Often what you'll find on the wards is they have nasal prongs and they have Hudson masks. And the problem with nasal prongs is they're shit, and the problem with Hudson masks is they're pretty much about as crap because they've got these giant holes on the side. So the actual oxygen they get in there is pretty useless. So if you can, always ask for a mask with a rebreather bag. And it's got the little oxygen bag, it sits underneath, it fills up with oxygen, and then that reservoir is what drives each breath in, okay? They don't have those almost all the time as well, which is pretty painful. But what you can do is get a bag mask. So same sort of thing used in resuscitation, get the mask, open it up, there's a PEEP dial often on it, so turn that to 0, because you don't want to be giving them any PEEP at the moment, per se. And then it's got the oxygen bag on the end that will blow up. And you just hold that over their mouth. You don't need to press it, you don't need to bag it, because as they take a big breath in, the one-way valve will open. Okay? So don't sit there and try and ventilate these people, they'll push you away. But just hold it over their mouth. It's a lot better than CPAP or something in terms of comfort for them, and it will do something. And of course, this is all while you're trying to get to CPAP or non-invasive ventilation. So CPAP versus BiPAP, I'm not sure how much you're aware of it, but obviously the idea of non-invasive is that you get that big dirty mask that gets strapped onto their head, and it gives them, it's sort of like putting your head out of the car window. So CPAP is when you shove your head out of the window and it's just constant pressure in your face all the time. BiPAP is two modes. So there's like a background PEEP, which is a positive end expiratory pressure, and then you've got your pressure support, which is a value that adds on top. So when they take a breath in, machine senses it and gives them even more support. Don't worry about all that necessarily. It's nice because when the registrars talk about it, you can say, oh, I know what BiPAP is. But all these guys pretty much get CPAP. So just head out the car window, that sort of thing. Okay. Bronchodilators, anticholinergics. I mean, obviously that depends. If you hear something that you think is going to be helped by those, by all means give it. And that sort of goes for the steroids as well. Most of them will sound pretty horrible when you listen. When you listen to anyone that's in acute respiratory failure, irrelevant of the underlying reason, they're going to sound shit. And you're not really going to hurt anyone by doing that. So you might as well do it. You'll often have to give it through nebulizers. Even though the spaces are better, nebulizers is the only way that it's going to get in because they're hypoxic and they need extra oxygen. Steroids, oral versus IV, doesn't make a difference. The only difference is A, whether you think you're going to need to intubate them and whether you think they can actually swallow. So if you're not going to need to intubate them straight away and they can swallow, let them have Pred, 50 of Pred, and that's fine. If you don't think they can do that, IV hypochlorite. And I guess then the circulation side of things for this sort of acute respiratory failure is just to make sure that other than all of this, they're not moving down the path of imminent respiratory arrest. Okay? That's the pretty boring slide. Obviously, when it comes to any of these, so that's the theory about what you do and what you're thinking about. In practice, you call a Met call straight away, if not a code blue. And that's not because they've arrested, and it's just because you're worried. You're really worried that this person is peri-arrest, going to need that extra support. Call it. You get the anaesthetist there, you get ICU there, you get everyone within about 4 blocks there, so it's good to call. Take control of the airway yourself. So it's scary when you're an intern, really scary, but move to the head of the bed and take control of the airway. Because it allows then, I mean, often people say when you're trying to be a team leader, you stand at the foot of the bed and you hand behind your back and you sort of give orders and stuff, and that's great. But you're not, when you do this sort of thing, when you get these pages, you're the only person there. You're the doctor. So go take control of the airway and then delegate people to do tasks. And at least that way, you've got a constant measure on exactly what's going on with regards to this person. What other tasks? So sending someone to get drugs. So often it's a nurse. And you give them a list. Just say, I want this, this, and this. You be direct, you tell them, can you please go and get this? Get someone else to be getting IV access. Get someone to be organising an IV mask. Now that will probably come with a Met call as well, but if you're already organising on top of it, you might get there a bit sooner. The reason why these people are in failure is not necessarily your concern. Your concern at the time is to work out if they're going to arrest and stop that and prevent it from happening. You can do an ABG or a VBG and get a full set of bloods once you get access. You can do an ECG, you can do a chest X-ray, but really what you're doing is trying to temporise the measures and temporise this person until someone arrives and helps. Okay? So that's any desatting, respiratory failure sort of patient. So now it's more specific. So obviously one of the nurses is asking, oh, it's got some asthma attack. 21-year-old appendicitis, sit on edge of bed, leaning on knees with arms outstretched. I don't know what I was getting at there. I was getting at like sitting out of bed like that. That's right, not outstretched like this, is it?
That always helps my breathing.
Yeah, yeah, everyone does it. She's speaking in short phrases, agitated. She's got all those other things going on. She's 99%, sat 99% of 2 litres, Hemodynamically, she's okay. Audible expiratory reads from the bedside, moderate accessory muscle usage, don't care about her abdomen, doesn't have an IDC. What do you think about this? So this is not an uncommon sort of asthma type thing you get in the hospital. So what are some of the things you want to be doing? What are you worried about? Is it good? Is it bad? Is she alright?
If her rhythm of breathing is such that she's leaning on her knees and her arms outstretched, I'd be worried that she is going to start failing or tiring soon.
Mm-hmm. Yeah, good. Good.
And she's young as well, so she has more reserve, but that doesn't mean we can just sit and wait forever.
Good.
She's saturating well, so she's got a fair bit of reserve nerve capacity, so I'm not worried that she's about to rest something in that respect, but I'm concerned because of the work she's putting in.
So what do you make of oxygen saturations in an asthmatic? In someone that's having an acute asthmatic attack, what do you expect them to be? Normal? Up until when?
The very like end.
Yeah, pretty much. Yeah. So it's one of the things that you might often get sort of frustrated about, because some will say they're just having a mild asthmatic attack, so it's fine, we've got it covered, we've given them, you know, some salbutamol once or something, a couple of puffs, because they're saturating okay, and it's a bit of a common misnomer that, yeah, they're saturating fine until they arrest, okay? So, but you're right, this person's not that great, and so obviously there's the asthma severity scale. It's supposed to grade between mild, moderate, severe, and imminent arrest. The reason I don't actually have a picture of it up on there is, I mean, it's based on all those things like, you know, breathlessness, can they talk, and it's got these, you know, a sentence or a phrase or a word or I don't know. And it's got these really definitive respiratory rate targets that put you from mild to moderate to severe. But really, I think it's crap. Really, in hospital and anywhere, the way you deal with asthma is the same. They're either peri-arrest, in which case it's a whole other separate ballgame, or they're not peri-arrest, but they're having an asthmatic attack. And it doesn't matter at what level they are, that might dictate to you whether or not you feel like you want more support there. But it's not going to change your actual initial management. So the only thing that I say that it's useful for is to be able to identify this sort of patient. So when you see someone, 21-year-old, same sort of asthmatic patient, that's now confused, she's drowsy, she's bradycardic, starting to become a bit hypotensive, cool peripherally, so she's starting to shut down a little bit. Now she's starting to desat on 6 litres. She's become, well, her respiratory rate's lowered. I don't even know if the word bradycardia, can you say that? I don't know, I've never really used it. But she's got a low respiratory rate. She's got quiet air entry, no wheeze. So the wheeze disappears right at the end. And it's because they're not moving air. And again, I'm sure you already know this stuff, but that's one you want to look at. The paradoxical abdominal wall movement, if you've ever seen it, just go to YouTube it or something. It's really interesting, and you'll never see it again. But it's something that everyone always mentions as a really, really late sign. And I guess in someone that is this bad, you might end up seeing them. But I wouldn't go looking for that and trying to make a diagnosis on how bad they are, because their abdomen moves up and down, not in time with their chest. Okay? But that's the sort of person that you want to have that for. That's why you care about the severity scale per se, because that's the peri-arrest. But everyone else, and even the peri-arrest, I guess, this is the sort of treatment plan that you want to instigate. So everyone gets bronchodilators, obviously. They get salbutamol. If they don't need oxygen, then you give it to them with the MDI, the metered dose inhaler, and a spacer. Okay? It just works better. The nebulizers often don't do that well, but you put up with them when you need to have oxygen support, because it's the only way to get it in there. You go 6 to 10 puffs, and you do it, repeat it every 20 minutes, and you keep going until they no longer need it. Okay? Keep going. They'll become tachycardic, but you don't care. Just keep going. There are the anticholinergics as well. You can give 6 to 10 puffs of those alongside with the salbutamol for the first couple, and then you stop. And there's steroids. And again, same deal as before. If they can swallow and they're not going to arrest, 50 of pred. If they can't swallow, and you've got IV access, and you've got the hydrocort sitting there, give them 100, 150, 200. Doesn't matter. A large amount of hydrocort IV. Okay? And then you keep watching, keep waiting. As the symptoms start to slow down, you can start stretching out their burst therapy of salbutamol and see how far you can go until you get to 4 hours, 6 hours, and then they're fine. Okay. So this is the other problem with asthma. I'm not really going to say it's a problem with asthma, but you can sometimes have this patient. So it's the same sort of patient, 21-year-old with appendicitis, sitting in bed, she's agitated, speaking in short sentences with a hoarse voice, she's really agitated. She's a bit tachycardic as well, warm peripheries. She's got a bit of a rash on her upper right arm and chest wall, she's flushed, Satin okay, slightly tachypnic, bilateral wheeze, a bit of stridal. Didn't look at her tummy, doesn't have a catheter. So what do you think about this sort of person? What are your thoughts as you're walking into the room?
Maybe good anaphylaxis.
Yeah, good. So I don't have to give this lecture, I can leave. No, the idea is that often people do confuse, especially in young people, asthma with anaphylaxis. And when they've been in hospital for a while, it can happen because you get so used to giving people morphine, giving people different, especially, morphine might be the one that people are a bit more certain about because they often watch it like a hawk. But any other medications, young people don't have medications ever. So when you give them anything, they could end up having an anaphylactic reaction to them. Older patients, it's more likely to be with antibiotics, antis that they didn't know they were allergic to, they've never had them before, they've got this new infection and you try, okay? But just to be aware that that is one of the big things that does sometimes get confused. So you get called to this patient that's got asthma, and all of a sudden you realise it's something else. I think we said already it's a clinical diagnosis, so there's no tests you do to confirm it. You look at it, you see it, and you treat it, okay? Call for help straight away. Now, I'm going to say it unfortunately, and it doesn't really happen that often, but when it happens, you don't do it, you look like an idiot, and that's stop anything that's running through. It doesn't matter what it is. Everything that's connected to a drip, disconnect it. Any patch that they've got on. People have patches on their chests or on their backs. If you see one, rip it off. Absolutely anything that's touching them that could be causing a reaction, take it off. Because it's not going to harm them by taking it off. But if it stays on and that's what they're allergic to, you're going to look like a real lump of paper. Okay? So take everything off. And then of course you've got your ABC approach. So airway in these people, it's primarily about protecting the airway because you know they're going to get a lot of edema. If they've got stridal, it's already probably not in a good stage. So you can, the beta agonists do help. The adrenaline, maybe it helps when it's inhaled. You can try it. Get these people on oxygen straight away, supplemental oxygen. And of course, IV access. And it's not just sort of part of the routine here, it is important because when it comes to the sort of the medications that you give, obviously everyone knows that you give the IM adrenaline. Outer thigh, hold it for 10 seconds if you've got one of those stupid EpiPens or something, make sure you don't stab yourself in the thumb. If not, just 500 milligrams of IM adrenaline, okay? It comes in little vials, it's easy for them to work out, not difficult. Repeat it every 3 to 5 minutes. So get someone to be taking the time, and every 3 to 5 minutes, go again. Probably say 3 minutes. Don't give IV adrenaline, just because the doses really are a lot different, and unless you're like an intensive care consultant, you've got these people attached to the monitoring, it sounds like a great idea, you think you can do it, but don't. So just IM adrenaline, it works well. And the other two that you'll have at your hand are antihistamines and steroids. So again, steroids 250 IV, and antihistamines, promethazine is one that seems to be around here or everywhere, and it's easy dose because it's 25. So 25, 250, 500, and that's easy, 4.5 if you've got depending on what bottle they give you. So that's all your treatment. In the meantime, you're waiting for someone else to come. Same sort of things, protect the airway, it's your responsibility until someone else gets there. And why it happens, who cares, not a problem. So trip days levels at 1 hour, 4 hours, 24 hours, whatever. The registrar can do that if they really want, okay? But you got to make sure you start this stuff. And this is reasonable as well for you to have happen as an intern. So
So just
Yeah.
to clarify, when it says as required, what?
So if they're still
when do you
symptomatic.
stop? Yeah, cool.
If you feel there's any symptoms, give them another jab of
Yeah.
adrenaline. It's fine. All right. So, oh, look at that sonata tachycardia. Who would have thought? So we've got an 81-year-old, she's sitting in bed. She's mentating okay, tachycardic, hypertensive, clammy, cap breathal times a bit high. Grade 2 to 3, pansystolic murmur radiated to carotids. JVP is not elevated, no peripheral edema. Satting pretty low on a Hudson mask, tachypnic, course creps bilaterally. IDC in situ, good urine output. Anyone have an idea of what we're looking at?
Could be APO.
Good. What kind of APO?
I'm unsure.
She could be having a non-steady.
Yeah, she could be. Good. So, the APO can be broadly separated into two groups. There's the hypotensive plus symptoms and the non-hypotensive plus symptoms. The idea being that they can sometimes move between the two, mind you. But most APOs you see will be someone that's dyspneic, they've got that bilateral wheeze, and they're hypertensive tachycardic. What's happening is, as their left ventricle is essentially, for whatever reason, failing, they get a huge sympathetic drive, catecholamines go through the roof, causes tachycardia, it causes arterial vasoconstriction, which then in turn worsens the APO, which then in turn increases sympathetic drive, and you get this vicious cycle until you get to the stage where they totally decompensate and they go into full-blown cardiogenic failure, and then all of a sudden their blood pressure drops and they're in a different stage of APO. Okay? And the second type, when it happens acutely, so when you acutely get an APO with the hypotension / normotension sort of stuff, the treatment can often really differ based on what the underlying cause is. Because the primary treatment of APO, as we're going to go into here, is the respiratory support. Okay, that's going to stay pretty much the same in both. CPAP, set the PEEP level to 6 or 8, and you can crank it up to 10 to 12 if you need to slowly. And this is where I have a lot of arguments with people. And so, by all means, take what I say with a grain of salt, with everything I say in general. But this in particular, GTN is your mainstay of treatment with these people, not furosemide. So, I'm not sure if you've seen someone in APO, everyone reaches for Lasix straight away. They said, got fluid on their lungs, what gets rid of fluid? Lasix. It's great, great theory. The problem is that these people don't actually have a hypovolemic state. What they've got is huge sympathetic drive. And this is in the type 1, hypertensive people, hypotensive tachycardic. They've got a huge sympathetic drive. They've got arterial vasoconstriction. They've still got a normal amount of fluid that's in there. So when you give them furosemide, A, it does nothing acute because how long does it take to pee out? Right? So it doesn't actually help you right then and there. And all it does is ends up taking the fluid out of their intravascular space, which they're not replete of anyway. So what you want to do is GTN. It gives you vasodilation of both arterial and venous sides, so it reduces your afterload, LV afterload. The way they give it is a little bit scary. I had one of these like a week ago when I was doing the sort of post-op recovery HDU. And it's scary because obviously if you're in hospital you don't necessarily give the subcut stuff, you've got an IV access, so you give an infusion. And the normal infusion rate that they're allowed to go up to is 50 micrograms per minute. So when I tell you that you're going to go up to 400 micrograms per minute, 8 times what their maximum dose is that any nurse will do for you. And you're going to leave it there for 2 minutes. And then you're going to drop it down and you're going to start at 100 micrograms a minute. It's pretty scary. So I do suggest one of the first things you do when you get in hospital is go and play with the machines that give fluids. Work out how to do it, work out how to increase the drip rate, work out how to decrease it, work out how to give boluses. Because it's sort of unfair to ask a nurse to do that. If you're this patient's side and you're asking a nurse to give 8 times what their maximum dose is, It's a little bit unfair. It wouldn't surprise me if they said no, especially as an intern. It'll happen. If you build rapport with them, maybe they'll do it. But, so make sure you can work all this machinery yourself. And it's not hard, it's like a button, okay? So the reason you got to the 400 for 2 minutes is just a loading dose. And then you drop it back to 100. And then you titrate up as needed. These people, when you put them on that, will very, very quickly become better. Their blood pressure will drop, their cramps will disappear, and you look like a genius, okay? The CPAP might not even get there in time. It can happen really, really quickly. If you dick around with furosemide and morphine, these people will go further. They'll go into full-blown cardiogenic failure, and then you've lost the game.
Is this
So,
mainly for your first group?
sorry?
This is for the first group?
Yeah, so the problem, so even with the normotensive patients,
Yeah.
you can afford to do it because even with the absence of any sort of immediate vasopressor or inotropic support, you've got blood pressure to play with. So you can afford to say, oh, I can do the GTN now. If I really need to, just stop it, okay? But when you get to the hypotensive end, it is still something that you do, but you don't do it immediately as your first sort of treatment because you need to make sure, you've got ready and available the stuff that's going to help you actually keep your blood pressure up systemically so that you don't become hyperperfused.
So the second group would be reasonable to start the sublingual and then sort of wait.
I would still,
Yeah.
so in the second group, again, if they're hypotensive, I would not do it at all.
Okay.
Just positive pressure and
Yeah.
like this is almost code blue.
Yeah.
So you could call a code and be pretty comfortable that you're doing the right thing.
Yeah.
Okay. But in the other sort of group, I mean, sure, this is a Met call anyway, probably, but you could start all of these things so that when someone else gets there, it's already done. And then just saying, okay, cool, I'll sit here and bump it up a little bit. Okay. Morphine as well, some people say try and use that. Yeah, give them a little bit if they're in serious pain, but I mean, it's not really helpful. It's not really harmful, but it's not helpful, so why bother? Okay. And these are some of the bonus points that you get. So once you've started the GTN infusion, once you've thrown the furosemide away and not given them morphine, and you've got them on CPAP, this is sort of the other stuff that you can do to try and narrow down now why they're in APO. So full set of bloods, ABG. You can do a BNP. It's not necessarily going to help you. It might help them afterwards. It's sort of a good marker of left ventricular dysfunction. So if it's really high, it could be helpful for them. They know they've got some form of failure. You can do your ECG to look for AMI or LVH. It's worth doing a chest x-ray, so you can call for a portable one. Every hospital will have a portable x-ray system. So every hospital, in inverted commas, will have a portable x-ray system. So call them, get them up there while you're doing all this and have a look, because you might find that it's not actually APO. Okay, I mean, if you've listened, it is APO, but you know what I mean. Could be something else, so just do the x-ray. An echo, obviously it's not something you're going to order acutely, but if you're thinking about it and getting the paperwork ready, it'll look good when the time comes. And the other one is make sure that they're on prophylaxis, DVT prophylaxis. Heparin, Clexane, whatever it is the hospital uses. Most of the times on the ward, they'll use Clexane. Some places will prefer heparin, but not too often, okay?
So if you push them into hypotension,
Yep.
you just stop the infusion.
Stop the GTN infusion and then start treating the hypotension. So in the absence of any other help, you can try giving fluid boluses, because it's not going to hurt them.
Yeah.
So this is the other tachycardia that we see. Oops, what have we done? So same sort of patient, she's sitting in bed, a little bit confused, she's got chest pain, hemodynamically doing her thing, cool peripheries, JVP's up in her ear somewhere, she's got a bit of peripheral edema, split S2 sound, destatting, she's got creps bilaterally in the lower zones, urine output was good and now there's only dark urine in the catheter. So we're talking about respiratory stuff, what else haven't we talked about yet? Yeah, fantastic. So it's not necessarily common, mind you. Let me just aside for a second, so back to intern world. It's not really common that you're going to get someone that's a massive P on the ward without anyone noticing, okay? But it's not uncommon that you'll have minor PDs that occur, so they might not be at this stage yet, but they'll be complaining of chest pain and no one really notices it because they're small, because they're not hypoxic, they're not really too tachycardic. So it's just worth keeping in mind that though this is obviously the crash patient, because that's the thing that you probably want to be told about in case it does happen, more often than not what you might see is really, really small subsegmental PEs that do occur. So just to keep in the back of your mind, because if you start treating it, you look really good. There are risk stratifying tools. So there's the PERC criteria, which is a rule out criteria, and there's the Wells criteria, which is a rule in criteria. There are obviously problems with each, but you have to know them relatively. Don't know them off by heart, but know what they are and know how you're supposed to use them. So if you have someone with a low probability, use PERC, and if that rules them out, you've done your job. You don't have to do anything else, okay? But because of the criteria, I haven't written them down here because like it's age, less than 50 or something, and like there are a couple of them that are never going to happen in your patients. So go to Wells, get a score, and what it really does for you is if you get a score of 1 or 2, or even just 1 really on the Wells score, which means by looking at this it's pretty hard to get 1, you can afford to do a D-dimer, and if it's negative, let them go, or not follow it up, okay? A lot of people hate D-dimers, and I'm sort of one of them, because the truth is that a D-dimer is going to be elevated in a lot of different scenarios, so you're never really going to get a low D-dimer. It's pretty rare to get a normal D-dimer. So if you're going to do it, just take the plunge and work out what's your next step, which is a CTPA or a VQ scan. CTPA, you'll get kickback from the radiologist saying, oh, the kidney function, the EGFR is only 70 or something. Well, that's fucking normal, it's fine. But they care about it, so start fluid. Start an IV bag of fluid over a long time, 6 hours before, 6 hours afterwards, and that's normally enough to calm them down. If they have VQ and you have access to it, you can do that, but it's pretty crappy. So again, this is sort of the massive sort of crashing PE patients. So it's not necessarily something that you will have to know how to deal with per se. But your sort of 4 goals of treatment for any PE are to decrease the pulmonary resistance. The only way you do that is by getting rid of the clot. So thrombolysis or thrombectomy. You optimize preload. Fluids aren't actually going to help because what they've got is right ventricular failure because of huge pulmonary hypertension, the fact that the right ventricle can't support it. So giving them fluids dilates it further and stuffs it up more. Having said that, in someone whilst you're waiting for vasopressor and inotropic support, you can give them 500 ml of fluid, okay? And at least you're doing something. It's not going to push them over the edge, but it might help that little bit, okay? The only other thing that you can really do while you're waiting for someone to come and help is ask these sorts of questions to see whether they're going to be a candidate for thrombolysis. Do they have a history of cancer? Have they had brain masses before? Have they ever had strokes? And when you ask about strokes, ask them, do you know if it was a clot? Do you know if it was a bleed? Do you know if it was one that turned into the other? Have they ever needed a CT scan of their head for any reason whatsoever? Have they ever, what's the other ones? Surgery in the last few weeks? That's pretty obvious, most people know that, and you probably know as well. Bleeding is something, I mean, you think someone would mention that they've got PR bleeding, but often people don't necessarily mention, say, oh yeah, there's always a bit of blood up there, it's normal for me, So yeah, maybe it is, but it's worth asking. And again, the other thing that if you really did have someone that had a massive PE, and this is maybe more in the ED rather than on the ward, ask them if they passed out and if there's a possibility they could have hit their head, because it means you'll have to do a CT scan first before you thrombolyze them. Okay? So these are sort of questions to make sure that they're not going to stroke out on you if you do thrombolyze them. Now this sort of moves a little bit sideways, but it's one of the other common things. Is everyone happy, by the way, with that? Again, I guess it's not necessarily something that you'll have to deal with by yourself, but as long as you can sort of cover hypoxia, tachypnea, some of the acute exacerbations, and you only have to be able to cover it for 5 minutes, you're fine. Okay? So this is the other one that you get a shitload of pages about. Fevers. Everyone has a fever in the hospital, and they page you all the time, and they want you to review. So when you go and review this guy, he's a 71 day 1 post-op elective right total knee. He's sitting in bed, he's febrile. His heart rate's 95, warm or perfused. Sats are fine. His bowels are fine. He opened them this morning. He's got a catheter in. Does he look like a sick patient? No. Good. So I don't know what you guys have been taught at all about fevers or about sepsis in general, but I never got told about this, about SIRS. I never knew what the fuck it was till I walked into a hospital and looked like an idiot. Right? So SIRS, Systemic Inflammatory Response Syndrome, was a term created in the sort of early 90s, I think 92 or something, by one of the ICU or intensive care groups in America. And it's basically used to define this systemic inflammatory response that occurs secondary to either an infectious or non-infectious cause. There are obviously some causes, I mean, ischemia, inflammation, trauma, yeah, okay, it's basically everything, sure. The definition of SIRS is what you have to care about. So there's 4 criteria for SIRS: temperature, heart rate, respiratory rate, or CO2, and white blood cells. You're often not going to have the white blood cells straight away, although if they had it from the morning, that might be okay if you've got bloods from the morning. But essentially what you're looking at is a fever higher than 38 or lower than 36 gives you a point. If you're tachycardic greater than 90, which isn't tachycardia, I know, but heart rate greater than 90 gives you a point. If your respiratory rate's greater than 20, or if you're somehow able to get an arterial blood gas, not venous, arterial blood gas with a PaCO2 of less than 32, that's a point. And then if you've got a leukocytosis or a leukopenia, greater than 12, less than 4, or greater than 10% of bands, which is something which your white blood cell gives you on the thing, right? So if you get 2 of those, then you qualify for SIRS. So going back to this guy here, he's febrile, that's 1. He's tachycardic, inverted commas for the SIRS, that's 2. The rest are fine. His CO2 is fine, his white blood cells are fine, so, okay? So he qualifies for SIRS. And the thing you have to remember is if there's an obvious cause, okay? So some of these things, ischemia, inflammation, trauma, infection, that sort of thing. Surgery, really big thing. So here we've got someone at day 1 post-op from an elective knee. That means he's coming from home. His bowels are working, he's peeing okay. What are the chances that this guy's turned septic on you in like 2 hours post-op? Pretty minimal, okay? So if you get this sort of patient and there's an obvious cause that could have caused SIRS, you don't have to do anything. You can just say to the nurse, this is a SIRS response, it's a normal inflammatory response, nurse / doctor / whatever. It's a normal response, we can observe it, okay? Now I do put a bit of a caution in there, and specific to fevers. And that's if you're not really sure. If you don't have a great cause, but you think you've got one, and you've got a fever higher than 38, it's probably worth just doing blood cultures anyway. And you could maybe argue at a urine full ward test or a chest x-ray, even though they've got extremely low yield unless they're symptomatic. But classically, if you have a PUO, which is sort of greater than 38, no localizing symptoms, and also for a short amount of time, but whatever, if you have temperature greater than 38 and no symptoms, chances are a quarter of the time to half the time is an infection that's causing it. The other ones, the tachycardia, the tachypnea, and the white blood cells, don't have that sort of correlation. So those you can more definitively say it's fine. But just with fevers, it's sort of a standard thing. The nurses want you to do blood cultures. You don't have to do them, but keep in the back of your mind unless you've got a good reason not to do them, okay? And as for chest x-rays and urine tests, if they're symptomatic, sure. So that's the SIRS side of it. Then obviously we have to go to the other side, the progression of SIRS. So you get, with that, the page about the fever, this is the other sort of person that you saw, which is a 68-year-old admitted with pneumonia overnight. And it's like the morning or something, so they haven't really had too much to look at. They're febrile, tiny bit confused, tachycardic, hypotensive, mold peripheries, all looking pretty shitty. Not doing too well with regards to oxygen, coarse creps in the right middle ambular zones. Abdomen, so be it, it's fine. No catheter, urine output, nothing since the coming. Bloods from the morning, got a marked leukocytosis with a high neutrophilia as well. Sorry, that's FB is hemoglobin first 109, white cells 23, platelets 201. UEC is sodium 136, potassium 4.3, so that's pretty normal. Chloride 108, okay, it's a little bit higher. Bicarb 18, it's a little bit low. His creatinine's 160, urea 15.2, they're pretty high. Normal creatinine like less than 80 sort of thing. BBG, so I couldn't do an ABG for whatever reason, but that's fine. So his pH is 7.26, so it's an acidemia. And I'm not sure if I told you guys this or if I was telling someone in the hospital, please don't say acidosis. Like, it's an acidemia when it's in the blood. It's a hypoxemia when your PaO2 is low, okay? It's an acidosis when there's a process that's going on. Same with alkalosis out, you know. So that's an acidemia at the moment, okay? I know, whatever, but who gives a fuck, right? But sure. Got a big base excess, -17, so like we were talking about before. Essentially what the base excess does, and I'll talk to you in another sort of set of lectures about sort of blood gases and how to interpret them, but the idea of the base excess is that the machines get rid of the respiratory component of whatever's going on. So they say, if we normalize a CO2, what's your pH going to be, and therefore how much of this base excess do you have? The idea of the base excess is that if you have a negative base excess, then you have a base deficit, which means you have an addition of an acid. So somewhere, there's on the metabolic side, there's an acid. That's all that's telling you. Do you have a question?
No.
Oh, cool. And the lactate's 5.3. Slightly coagulopathic, and this person's not on warfarin. APTT's 38. So what do you think about this?
Sepsis.
Okay, so I had two things. I had sepsis and I had septic shock. So what are the differences? Who said sepsis?
I did.
Shock.
Severe sepsis because he's got end organ compromise.
Okay, good. So that's good. At least we've got the terms. So we've got sepsis, we've got severe sepsis, we've got septic shock. What else is there? What comes after septic shock? Yeah. Or MODS, multi-organ dysfunctions. So this is the way that you classify. Everyone gets it wrong. Absolutely everyone gets it wrong. And people just say sepsis. They don't necessarily, we don't really, or haven't been taught what it's supposed to mean. Sepsis in itself is when you're SIRS positive and you have a suspected or a grown source of infection. That makes you septic. Then you move down the line. Severe sepsis. So that's when you've got sepsis already, which means you're SIRS positive, you've got a source or you suspect a source, and you've got evidence of what they call here organ dysfunction, hypotension, or hypoperfusion. Primarily what it means is lactate greater than 4, or on the hypotension side, a systolic of less than 90 or a MAP of less than 65. So when you get those criteria, and you just need one of those, when you get those criteria, you're now in severe sepsis. You move down the line, you get to septic shock. That's when you're still in the severe sepsis criteria with regards to your hypotension, despite adequate fluid resuscitation. And that's not 500 ml of fluid. That's like a good amount of fluid. We'll talk about that in a little bit as well. And then you get down to MODS. And that's when you have still SIRS criteria with evidence of 2 or more organs failing, but plus all sepsis as well, sepsis criteria. Okay? I'm going to be a bit punctilious again with this bacteremia. Just because someone's got bacteria in their blood, it doesn't mean they're septic. So, bacteria in blood is a bacteremia. Okay? And the reason about this that it makes a difference with regards to sepsis is because all of the trials that were done, here we go, yeah, early goal-directed therapy. So this guy, Manny Rivers, in 2001 published this article, or this trial, which was basically looking at people that are in severe sepsis and septic shock. It was one of the sort of landmark trials in current septic care. And the idea was that he was looking at a couple of other features which you don't necessarily get, which you won't have nowadays, like central venous oxygenation and that sort of stuff. But what essentially came out of it was that septic people need a lot of fluid, so you dump fluid into them, and the earlier you get your antibiotics in, the better their treatment outcomes are for mortality directly. So, and it's by the hour. So hour by hour that you go by and don't give these people antibiotics, their mortality increases by like, you know, up to 10% an hour. So pretty significant. The only reason I really care to tell you about that, not that I care about the trial per se, is because what it means is that when you get someone that comes in, that sort of fever, the patient that's on the ward, they got admitted overnight with pneumonia, and no one decided to look at their bloods because the admitting resident said, oh, I'm going back to sleep. Okay? You obviously want to work out, quantify exactly how bad they are. So do blood cultures, do lactate, send off all those bloods because you're looking for any of their organs to make sure they're okay. Chest X-ray and urine MCS, like we said before, they've got a pretty poor sensitivity in patients that don't actually have symptoms, so respiratory or urinary symptoms. But just do it. Why not? Like, I know I'm telling you that it's shit, but do it. Okay? In terms of the antibiotics, I haven't listed up there what antibiotics to start because they're online. Go to therapeutic guidelines when you do it. There's a whole different list, and essentially what it looks at is whether or not it tries to identify what system you're looking at, and then it gives you broad spectrum antibiotics depending on that system to start. Okay? The only thing you have to take out of it is if you can do everything else, i.e. your cultures, before 45 minutes, then you can withhold your antibiotics. If you're not going to be able to do it within 45 minutes, give anti straight away. Okay? You might get the registrar, the med reg that says, oh, we don't have an antibiotic-free culture, whatever. Doesn't matter. All right? So 45 minutes is your time window. Now fluid, so fluid resuscitation. So the way that they sort of define adequate fluid resuscitation for sepsis is 30 mils per kilo of fluid. So if you're looking at, when you think about how much fluid that really is, like a 70 kilogram guy, that's talking about, before you can just say that you've given them a good shot, you have to give them at least 2 litres of fluid. Okay? So all that this is supposed to make you think, if you take anything out of sepsis, it's early antibiotics and start dumping fluid into it. So big cannulae, both arms, and bags of fluid that you're squeezing if you have to. Okay? It's not uncommon by the time these guys get to us in ICU that they've already had, in a short period of time in ED, before they were able to get central access and start vasopressors, before they were able to start all those other things, they've had 6 litres of fluid. Okay? That might be, some might argue, is now pushing the boundary of, because, you know, there's talks about whether you use little or more, but everyone pretty much agrees that between 3 to 4 litres of fluid in these people is what you must give. Okay? So don't be afraid of giving them fluid. Steroids, I put them there as bonus points, just because some people use them, some people don't. We're doing a trial at the Austin now to see whether it actually makes a difference at all in septic people, septic shock, when you give them steroids. If you're going to do it, give them IV hydrocort, 100 milligrams, and chart at QID. I put 50 to 100 there because some hospitals actually have a guideline of 50 instead of 100. We use 100. So you can do that if you really want to. Try and locate the organ that you think is causing it, because that's going to define your source control, and that's the only way to get rid of sepsis in any sort of patient. Okay? So it's not going to do much for you necessarily as you're doing the resuscitation, but it's maybe worth just keeping an eye on and seeing if you can narrow it down. And the bloods might help by the time you get there. I think that's it. Any questions at all about sepsis, about respiratory problems on the ward, about blood gases?
With that, this is probably a question. The patient who had the PE,
Yeah.
What, like, they had bilateral crepitation, right? What for you, then you go, oh, this is definitely PE and not another APO case or something? Like, how do you, because it's quite different management, and I just don't know if I get there in a bit of cluster, if I'd be able to.
Yeah, no, you're right. It's, where is it? I just wrote that down. Oh, I'll script the position. I think it's this one here. So I guess the reason that I have that in there is because almost any patient that you have in hospital, if you listen hard enough, will have bilateral basal crepitations. So how do you make that diagnosis of PE there? You can apply the criteria, they're pretty good. The reason that I tell people, and I apply the criteria as well, the Wells score in particular, is because even though it's not great, it's sort of been shown to be as effective as a senior physician's general impression. So if you get, head of gen med that walks up and says PE, and you apply the criteria, you're going to be right about as many times as him or her. Okay? So apply the criteria, have a look. In this person here, like, why do I not care about the creps? Well, do I think that's a problem? I don't know. Maybe I would. I mean, I wrote the question knowing what the answer was, so maybe I would. I don't know. But it's something you have to think about, that not everything that you will see on the wards is going to have those definitive textbook, only this problem and everything else is normal sort of things. Okay? Obviously in this you can say that the split in the VEST2 and the JVP and stuff is indicative of something in right heart dysfunction that's going on. So, but I agree with what you're saying. It's something you'll have to learn to deal with. You'll have to learn to sift through the shit. So work out what do you care about now and what isn't your problem. And when I say not your problem, more what's not the problem of what you're treating right here and right now. What do you expect to be there? Any other questions at all? In general? All good. So, what else should we go through? Not now, obviously, but I need to get home. But what else should we go through over the course of the next couple of weeks or something? Anyone have any questions?
ABGs?
Yeah.
ABGs you could get.
Okay.
The dummies.
Sorry?
The dummies, like.
Yeah.
I mean,
ABGs are simple. They really are.
yeah.
Just more on the variable you can do it on.
Yeah.
Because
Doesn't work with better than hindsight.
Yeah.
Do you get shit scared a lot?
Yeah.
ABC, remember that. Remember that over and over and over again, because that will get you out of trouble all the time. So.
Low GCS approach.
Oh yeah. Yeah, I think I was going to do that. Yeah.
Actually, not cool.
I'll do that one next then.
Actually, not talking.
Why don't you
That's all I
still
got.
think it's fine? It's fine.
Should have been
Me.
cool. That's all I got. Just love decrease.
decrease you and
How about?
Yeah, so I guess what I was...
How about? I'll send you the instructions.
We can go